Primary care is the starting point for all medical care. The very availability of a specialist to be able to take the time to do something that it would take a physician a much longer time to do. So if I spend an hour with a patient talking to them about their medications, in that hour I could see 3 other patients, but it's something that a clinical pharmacist could probably do better and faster than I do. In that sense, it's a win-win in both scenarios.
It's a big advantage. I mean, it helps free up my schedule so that I can see other patients who maybe don't need quite as an intensive management. And I think improves the patient experience as well.
We've used our clinical pharmacist in a leadership role to develop protocols and in an educational role when we're trying to implement a change in care.
We're in a family medicine clinic. Here we do a fair amount of what's called population health or population management, and it's looking at the whole population of patients with diabetes or hypertension who are patients of this clinic, and then specifically looking at the medication regimen for those patients.
I know that I'm offloading the providers because they're telling me that they're sending those people to me, I'm managing them to goal, and then they have more spots and openings to see different types of patients. And so I know I'm saving them time, and I'm helping all the outcome numbers to look good too, because those things are getting done.
When I have a patient who is just not succeeding and they need a little extra attention, I've used the clinical pharmacist to add medications to find out really why they're not able to manage their diabetes, and she'll have the time to figure that out.
I see the highest risk patients in our population that have diabetes, the ones that are not successful with the usual standard of care with their physician. I can help when everything that they've tried doesn't seem to be working.
We've come to really rely on them. We see the people either when they first get diagnosed or when they've had it for a while and just kind of stalling, and then they go in for 1 or 2 visits with the pharmacy docs, and it's like the light bulb comes on. All of a sudden they're watching what they're eating, and they might switch their medicines a little bit, get them something that's easier to tolerate, and the people just feel happy because they're successful. They're like beating their disease or at least controlling it.
We can kind of partner together. Now the other difference is that when they get referred to them, they're referred for that specific problem. And so that's a focused visit where the full time is spent talking about that, counseling, and managing their medications.
We don't have enough time to manage some of these more complicated patients, and so I think having her do the educational piece at first has improved trust, and then the last step is co-management, where she's really seeing them independent of me.
So I think team is a very key word, and it's very, very collaborative. And so I see myself in this environment as a consultant looking to improve the medication regimens of patients in the context of what the other team members do.
Definitely seen the need for mental health care and specifically management of psychiatric medications. If you can make a protocol that provides some algorithms for managing psychiatric medications, clinical pharmacists can help fill that need. And you always have the oversight by the physicians, by the providers, to check in with those patients periodically and make sure things are going well.
Really, the special thing about it is that the pharmacist can really take that extra time with the patient to focus on the medication specifically.
Our high-risk HEDIS measure is something that we have been really looking at because we have several Medicare Advantage plans. I've been really working hard to get that measure down. When I first started for one plan, the measure was hanging out around 11%, and with those chart reviews that I did, we got it to be below 3, which was a huge improvement.
We've actually been able to measure some good improvement in clinical outcomes. We've seen as much as a 2% decrease in A1C. That's a big deal.
I've seen the difference, and I've had those times where I want to reach out and have that referral source, but I just don't. Whereas here, I do. And so look at your environment, see what fits for your practice, align them with the other providers so it's a visit that the patient goes to. I think however you can fit it in, it is a great resource to have.
Be patient about working on the culture piece of this. For a while, we did not have our pharmacist seeing patients individually on the side, but rather developing protocols and doing an education piece. She was able to have a leadership role where we recognized her skills, and then it was developing trust and, wow, she knows her medications, I can't keep up on all of these things, and then providers were more willing to refer patients to her for co-management.
We're here to help and to do whatever the clinic needs.
It improves the provider experience as well.
Plus you feel like, how did we get by without them?